Oh, there you go. You said that the other.
All right. Pull everyone together.
Yeah. I work from home.
This is pretty cool, huh? Put this here, put it here.
Is it working? Oh, that looks right. It's working. Skull is rotating around.
So,
It's pretty fancy. How are you, Dave?
doing pretty good. Excited. I think this will be nice. Got cheese and coffee.
Yeah. Was that you that organized that?
Yeah.
That's very nice. I'm going to go enjoy some.
Yeah. How do you think I should bring people in? Just like start talking?
Yeah. I think we're ready to get started now.
Very good. All right, folks. Hello.
Everyone did sign in for me.
Sure. Hi, folks. Good evening. I think we're going to get started. Welcome to our December meeting. We're very happy to have Dave Boyland with us here today. Just wanted to give you some housekeeping notes. Make sure you sign in if you want the CEUs. And we have coffee and tea in the back. Dave, it's an honor to have you here. Thanks for coming to do a talk for us.
Thanks, Dave.
So Dave is really a man who I think needs a little introduction. An athletic trainer before you were a physical therapist, and a sports certified specialist, owner of a private practice, a professor at Upstate, and we're just really happy to have you here, Dave.
Thanks, Dave.
Thank you. So you can just clip this to your lapel and put this in your pocket.
Very good.
Should be good to go.
Awesome. Thanks, Dave. All right. So I appreciate everyone coming out tonight. Hi, Kevin. Hi, Dave. And I really look forward to being able to, and I really appreciate Central District offering the invitation. This presentation is a combination presentation. So some of the slides are original slides from Scott Musgrave, who I'll show you a picture of in a minute, who developed this technique, AAT. But yet there's some collaboration in here. So I'm going to get through quite a little bit of slides here fairly quickly, and then I have two case presentations. Matt Carey, who's at St. Joe's, and Amanda Davies, who's at St. Camillus. So one from acute care, one from subacute care, just to show you how this really works in the broad spectrum. I'm using it in the outpatient setting, and as Dave said, the thing that's really interesting for me in this process, because I've been involved in this now for about 3 years, and John Borden, who's sitting in the back, is also an Upstate grad who introduced this to me and has been mentoring me in this. But for me, this was a real transformation of my practice, because this was not who or what I was. These are the patients that I did not appreciate seeing. These are the patients that I hoped would end up on someone else's schedule. And now I'm helping and working with people that all of us have struggled with over time. And hopefully as we go through the next 45 minutes to hour, you'll see more of that. So one of the things that I need to introduce also is the fact that in the slides or on the emails that the technique is called associative awareness technique. But as of 2017, Scott is changing the name. So it's going to be autonomic awareness training. So the slide presentation will speak to those terms. So if I mix the terms, that's just old habits, new habits, old eyes, new eyes for those of, but the reality is it's the same technique. It's just being renamed. And Scott really has believed for a long, long time that it really is the autonomic connection. It's the autonomic nervous system connection that is the thing that makes it so unique. So this is Scott, okay? And again, he's the founder of AAT. He works with a group of individuals. He's not a fly-by-night sole practitioner. He is a physical therapist, but he has a committee of people, neuroscientists, neurologists, all kinds of other people that he's constantly using, referencing to help to pull this information together. So this is where this brainchild has come from. So the first question is, what medical term defines balance? And when we talk about balance of the body, healthy living, one of the terms that comes to mind from physiology, from science, is homeostasis. Homeostasis is balance. But we're going to introduce a term tonight which is allostasis, which may or may not be new to you. But homeostasis is the stability of physiological symptoms that are essential for life. They're maintained within a range optimal to current life history stage. So it's a single point equilibrium. So if it's pH, then it's pH equilibrium. If it's blood volume, if it's oxygen levels, whatever it is, the body is designed to maintain each and every one of those things in homeostasis. But the way that it does it, okay, so homeostasis, if it worked in individual cases, what would happen is if I'm out in the desert and I'm sweating and I wanted to maintain homeostasis, I want to maintain my body temperature regular, I would dehydrate. I would eventually lose life because my systems wouldn't balance each other out. But we know over time that through allostasis, you achieve stability through physiological or behavioral change. So my kidneys would begin to function differently. They would start to maintain fluid levels and things like that maintain me from dehydrating, and so I would be maintaining several homeostatic points all at the same time. That's allostasis, okay? And it really distinguishes between all the systems, and that those are the things that we adapt and change if we are put into different situations. And it's allostasis that we're really after. And you're going to find that when we talk about a lot of individuals who have a lot of chronic conditions, chronic diseases, they have multiple system issues. Their body is not in allostasis. So we're wondering, why can't we get this musculoskeletal system in order when all these other systems are not in order either? So just, again, from a physical therapy standpoint or a musculoskeletal standpoint, we deal with muscle guarding all the time. We deal with protective muscle tension. We deal with recurrent patterning. The body keeps going through the same pattern over and over again for any number of different reasons. Joint protective reflexes. These are all a function of the autonomic nervous system. So we're trying to get the body to make a change, and we're trying to eliminate some of these negative patterns. But if the autonomic nervous system is firing the same messages, then they continue to come. So you might do something that might affect them for an hour, might affect them for a day, might affect them for a week, but their body seems to be going back to the same point over and over again. And that's where the autonomic nervous system comes in. So again, not new to anybody here. The autonomic nervous system, okay, is basically sympathetic nervous system activity, parasympathetic nervous activity, all right? Sympathetic being excitatory to the systems, parasympathetic being somewhat inhibitory. And we're going to talk a lot more about that later on in the presentation. So I'm just introducing some of the basic things just to make sure we're all on the same page, okay? The autonomic nervous system controls every tissue, every organ, and every system in the body. So if you want to make a change in an individual, the autonomic nervous system is a great place to start. And again, you see here that when we look at all the systems, the musculoskeletal system is just one of many systems. One of the things that you learned, especially in physical therapy school or physical therapy assistant school, is that you always wanted to recognize what we called, red flags or yellow flags, all right? What other conditions does this person have? What other medical, seemingly unrelated conditions do they have that's going to interfere with their ability to exercise, or it might interfere with a particular treatment? So we need to know about these things, okay? So, that's the way I was trained. That's the way I practiced for over 20 years, is looking at these things as unrelated. But the reality is, when I recognize the role of the autonomic nervous system, they're all related. So one of the joys of my practice now through AAT and through the practice I have now is the fact that I get to celebrate with my patients and say, no, this makes perfect sense. if you look at it from an autonomic nervous system standpoint. If you look at it from an individual system standpoint, it looks like all these unrelated dots without any connection. But the connection is the autonomic nervous system. So, oh, by the way, I also have. Great. That tells me your body is not in allostasis. So, therefore, getting your musculoskeletal system into a place of normal function is the body doesn't have a home base, I tell them. I said, you lost your home base. Okay? So any of these conditions, any of these systems, and one of the things that I love to talk to patients about also is when I talk to them about the immune system, I say, what does the immune system do? What would you say? What would you say the immune system does? What have you learned? What do you tell your patients? What does your immune system do? Fights off infection. It's your protector. It's your defender. But you know what your immune system really is, if you looked at it more carefully? It's your growth system. Why did my body choose from age 0 to 21 to grow at such a rapid rate? Why does it choose now to do things differently? Why is it choosing to grow white blood cells now? Well, there's some organism that it needs to respond to, so it's growing white blood cells. Why is it growing cancer cells now? Why is it growing these cells now? That's what our immune system does. It grows things. So when it gets out of balance, cells that we don't want start to grow, or cells that we do want stop growing. And if you think about it, if you're made of 100 trillion cells, your body, if you go back to basic biology, is designed. What do cells do? They divide. They reproduce. They regenerate. So why does my body degenerate if it was designed to regenerate? And each cell is designed to regenerate. Well, something is signaling it. Something is telling it, oh, no, don't do that. Do this instead. This becomes its new pattern. And so these individuals who start down this pathway start to develop more and more organ system problems, and they say, well, why is my body falling apart? Why am I having all these issues? Because your body's not growing and regenerating in the way that it was originally designed, for example. Okay? So how do you target the autonomic nervous system in your treatments on a daily basis? What are you doing to say, okay, I'm really going to address this autonomic nervous system? All right? Interestingly enough, if you've gone through physical therapy school or even physical therapy assistant school, you had courses in neurology, you had courses in neuroscience, you had courses in physiology, you had courses in behavioral psychology, but they're all unrelated. No one ever connected the courses and said, how do you use this to impact the body, impact the system? Well, AAT uses those sciences. It's a science-based program. It's not just pulled out of the wind. It's a science-based program that uses the science of all of those things to effectively make change in the autonomic nervous system and eventually in all the systems of the body. So what are the primary functions of the brain? Creating sensory reality, integrating information, producing behavior. Okay? So it has to integrate information. It has to create a sensory reality. For a lot of your patients, guess what? Their sensory reality is not correct. It's incorrect. I wake up every day, I have pain in my back. That's a wrong answer. Why doesn't the body change it? Why doesn't the nervous system turn that signal off? Because its sensory reality is that's what it is. That's who it is. Okay? And so it affects how their brain integrates the information. It affects how they react and respond in their world. Okay? And when we talk about systems, again, remember, what is the gut made up of? Smooth muscle. What are most of your organs made up of? Smooth muscle. We're still talking about muscle function. We're still talking about changing how this behavior, when I talk about behavior, I don't just mean my behavior in society, my behavior with individuals. How does my body behave? How does my gut behave? How are my kidneys behaving? How's my immune system behaving? What is my brain telling it to do based on the sensory reality that it perceives? Okay? So the central nervous system is like a processing plant. Collects, transports, and processes information at a magnitude it's so hard to comprehend. All right? So somewhere along the way, we need to interrupt that processing. We need to change that processing. Very simply, input plus processing equals output. Okay? So as physical therapists, we tend to think that we do a pretty good job working on the input. If I can mobilize this joint, if I can apply a modality, if I can get the person to experience an exercise, that's going to change the input that should affect the processing center and ultimately get an output. And oftentimes we can do that in situations. But oftentimes our patients come in with systems that are so far out of balance that we can give the best input, but it doesn't seem to make a difference. Or if it does, it doesn't seem to last or doesn't seem to change very quickly. Okay? So that's what we're talking about in this regard. We all do this, but the question is, what do you do with those patients or those situations where your best techniques, your best modalities, your best exercises are either not working or getting an adverse reaction? That doesn't add up. Okay? So this actually comes from an article that was in Physical Therapy in 2011. So this comes out of our own journal. Okay? And basically one of the conclusions of the author was said that pain has clear emotional and behavioral consequences that influence the development of persistent problems and the outcomes of treatment. So we as physical therapists have been taught to recognize that pain is multidimensional, that there's an emotional component, there's a psychological component. And one of the things that I love is patients will come in and I'll start to talk to them about this and they go, wait a minute, you're saying this is in my head. I go, good news, no, it's not in your head. It's in all of you. Because without a head, without a processing center, you have no pain. You have no experience. You have no sense for reality. All of our pain is in our head. It's in our entire body. But the reality is we recognize that there's multiple components to it. And so therefore, I'm saying your pain is real. You're not making it up. There's nothing that you're fabricating. You're feeling it. Your system is feeling it. It may not match an anatomical model. It may not match a specific tissue. So therefore, the doctor scratching his head or someone else is scratching their head saying, oh, this is, I don't know what to tell you. Okay. My favorite one, I have a patient recently, she goes back for the umpteenth time to see her doctor for a hand fracture that she had in her metacarpal. When the doctor puts the x-ray up, says, I don't understand it. The x-ray looks fine. I don't know why your hand's hurting. Well, there's many reasons why your hand is still hurting. The x-ray is not the be-all and end-all. So this study came out of Britain, okay, and it says physiotherapists may stigmatize or feel unprepared to treat people with low back pain and psychosocial factors that influence recovery, a systematic review. So they did a huge systematic review. They looked at this, and this is basically one of the conclusions they came up with. And by the way, I'm not picking on chronic low back pain. It's just that there's a lot of good literature on chronic low back pain. If you do, just as an interesting, if you do an upstate search, an upstate library search, and you put in chronic pain from 2012 to 2017, there's 17,000 holdings that have chronic pain in the title or the description of it. 17,000. So this is not obviously a small issue, but chronic low back pain is one of the more popular ones that's been more recently studied. So one of the conclusions was physiotherapists perceive that neither their initial training nor currently available professional development training instilled them with the requisite skills and confidence to successfully address and treat multidimensional pain presentations seen in low back pain. So the physical therapists interviewed in these studies that showed that it was pretty consistent that we're not trained. We don't have adequate training to handle multidimensional pain. Okay? So how have we handled multidimensional pain up to this point?
Refer them back to the doctor?
Refer them back to the doctor. Or we have like low back programs that would include a psychologist, that would include a neurologist, that would include PT, that would include, so we'd have a team of individuals that would be trying to manage these people with these chronic conditions, because it would take a team to deal with all of these separate components. And so one of the studies that I looked at these multidisciplinary biopsychosocial rehabilitation chronic low back pain teams, and they did a Cochrane systematic review meta-analysis. Okay, so they looked at, again, teams that involve a combination of physical, psychological, educational, and/or work-related components delivered by a team of healthcare professionals with expertise in different fields. Conclusions from these very multiple studies: the systematic review would provide evidence that multidisciplinary rehabilitation programs are more effective than usual care. So usual care meaning medications and rest, you know, basically conventional care, okay? That these programs were moderately better than that, okay? But they also found that there was low quality evidence when they compared them to physical treatment. So when we look at what we're used to doing with low back pain patients, there wasn't a big change necessarily in decreasing pain or disability in people with chronic low back pain. So again, it's a great concept that, okay, if pain's multidimensional, we'll have a multidimensional team, we'll get great results. At this point, we're not seeing it. It's not happening, okay? So what do we do, okay? So going back to looking at the central nervous system and recognizing how the central nervous system functions in each and every one of us, okay? Experience creates learning. Learning creates memory. Memory creates behavior. So we know that these people are experiencing things, that their bodies are behaving in a certain way that is inappropriate, okay? They just have back pain. They have dysfunction. They have all of these other issues. But the reality is, when you look at that cycle, the biopsychosocial cycle, that cycle keeps over and over, going over and over and over again. So where do we interrupt the cycle? Okay? Where do we typically interrupt the cycle? We try to interrupt it at the processing level. You know, people go to counseling. They go to psychologists. And so, okay, let's get your brain to experience differently. Let's get you to reprogram your brain. Meanwhile, the input from their body says, hey, this still hurts, but let's get you to think differently. Let's get your output to be different by starting here, at the processing level, okay? And so you'll see all of these people, and they may be going to counseling, they may be going to other people, and they say, oh, you know, I'm going for 9 years, and I have a good relationship with my counselor. Well, how's it working? Oh, it's not really working, but it helps me, and it makes me feel better about my situation. But ultimately, if we can change the input, which changes the experience, now you're going to get a different experience out of that same central nervous system. So we're the part of the biopsychosocial model. So we need to look at how we're creating or changing input, okay? So this is a study out of Europe where they took 42 therapists who were dealing with patients with chronic low back pain who were experienced therapists, and they had two groups, a control group and an experimental group. So the experimental group went to an 8-day course at a university looking at psychosocial risk factors, becoming more sensitive to psychosocial issues, and trying to incorporate more of that into their practice. And what they found was those patients who had higher levels of depression or higher levels of other conditions, including their low back pain, felt better when they were being treated by a therapist who had been to the course, who had sensitivity towards some of these psychosocial issues. And so, you know, they said, okay, this was better than doing nothing, but ultimately we're still primarily being trained in the biomedical model, in the biomechanical model, and we're not being trained in that biopsychosocial model. So again, in this situation, it showed that it was better than nothing, but again, all they really showed was there was more sensitivity, but they weren't necessarily much better at treating these patients, but their patients felt better about those interactions. Okay. So where is this going to occur in the brain? The answer is going to surprise you. Okay? So when you first have an experience, as you learned in neuroscience class, all right, and you should all remember this. So the first thing is it's going to be sensory to the spinal motor, okay? So that's where our basic reflexes are, okay? Then there's going to be communication, okay? To the sensory to the brainstem, okay? And that's where our autonomic nervous system is primarily housed, okay? Then we're going to go up to that point, up through the limbic system. Now we're going to start to have more emotional experiences, more emotional connections that are going to relate to our pain. And then eventually, it's going to get to the cortical, okay? And the motor. So all of these levels are experiencing this experience, okay? So where and how do we affect that? At any one of those levels, but primarily if we can affect it at the beginning, okay, either in the brainstem or in the spinal cord, then we can make change very quickly, okay? After that, it gets much more complex, okay? So again, that's just your neuroscience in a nutshell. So this is Dr. Robert Scare. He's a neurologist out in Colorado, and if you know anything about neurologists, they should be extremely frustrated, okay, because they only get the dumping ground of people who don't need surgery, who have neurological conditions, and so their job is to make do with these people, and oftentimes they're in chronic states and are progressive disorders, okay? But what Dr. Scare started to take a lot more look at wasn't the disease process, but what was affecting the disease process. And if you think about the definition of disease, all right, if you go back to third grade and your teacher said, what does disease mean, you would say what? Because you were taught to break words down in third grade. Okay, so take the word, all right, dis meaning bad, okay, ease being ease, all right? So it's a system that's not at ease, all right? So that's what the word means, okay, by definition. Where did chronic become synonymous with disease? So when you look at the body and you say to yourself, well, the body is not at ease right now, it's making wrong choices, but we can reverse those choices. Now this disease process that we consider to be progressive, now these disease processes that we consider to be degenerative, don't have to be chronic or degenerative if the body is at ease or if the systems are at ease, okay? So he started looking at the effect of trauma, okay, on these patients with these particular problems, whiplash and other types of things, all right? So trauma is defined as any negative life event in the state of relative helplessness, okay? So the key term here, trauma equals helplessness. Helplessness equals excitation. Excitation of what? Of the autonomic nervous system. Okay? Your body is going to react strongly in a helpless situation. Okay? So where does this begin in our lifespan? It begins in childhood. Okay? So many diseases thought to be psychosomatic, for lack of a better explanation, are now seen as directly related to trauma. Our bodies remember in finite detail the sensory pattern of trauma. Okay. Trauma, your body has no ability to forget. Understand that. You don't have infinite ability to recall all of those subconscious things, but your nervous system catalogs those things because it needs to catalog those things. Because those things you don't want to forget. You don't have to get up in the morning and go, okay, I got to go to the stove. I got to remember what a hot stove feels like. No, I don't need to do that every morning because my body cataloged it when I was 2 years old or 3 years old or whenever I had that adverse experience. It's cataloged it for your lifetime. It will catalog everything. Okay? So these patterns become built into us, and then our body will draw on those things as we go through life and we progress and get older and older. So if you haven't looked at this information, this is something that you should spend some time taking a look at. This comes off of the CDC website, okay? This is a very large-scale study which looked at adverse childhood experiences. So they surveyed over 17,000 individuals that were in the Kaiser Permanente healthcare system in Southern California, and looked at how many people recognize having had, and we'll get into that in just a minute. But one of the things that they've looked at now is that if you have had adverse child experiences, trauma equals helplessness, it disrupts neural development. Okay? How many kids are struggling with diseases or disorders more so than ever now, and also including adults? That will cause social and emotional cognitive impairment. That will change an adoption of health risk factors, so my body will start to make wrong choices. Disease, disability, and social problems will ensue, and interestingly enough, so will early death. So my really difficult patients, one of the things I explained to them is I said, I'm okay with you dying 20 years before your time. If you are, I'm okay with that. But if you're willing to listen to this, understand that this is not just affecting how you feel today. This is not just affecting your family structure today. This is going to have a huge impact as you go through, because your body is showing signs of maladaptive neurologic behavior, and those things can be corrected for. If they're not corrected for, this low back pain you can keep the rest of your life, this diabetes you can keep the rest of your life, this depression you can keep all these things for the rest of your life. But the studies show those patients with fibromyalgia, those patients with multiple system conditions have early death. Okay, so this is not mess around kind of information anymore. This is very serious information, starting with childhood adverse experiences. Okay, so again, I'm not going to spend a lot of time going through the data, but you can see here the number is huge, 17,000 patients. Okay, but what it shows is, again, abuse, emotional abuse, physical abuse, sexual abuse. Okay, mother treated violently, household substance abuse, household mental illness, parental separation or divorce, any number of these different things. Okay. Now, the other thing I want to say is these are people who have an awareness of these things. You know, there could have been sexual abuse when they were 6 months old. They don't even remember it, but their body experienced it. So this is just what people reported. Okay, this may only be the tip of the iceberg of what potentially is behind all this. And again, it's looking at all of these factors. So one of the things that we'll do, if I have a patient that I suspect has had multiple traumas, is all I will do is give them a trauma list. I'll have them sit for a few minutes. I leave the room, and all I say to them when I come back is I say, I don't need to know what it was. I just need a number. And they'll look at this list, and they'll come back and they'll go, 17. You remember 17. And again, these are multiple traumas up through adulthood and things like that, more than just childhood traumas. But it's them recognizing that those experiences are now showing up as maladaptive neurological behavior or system failure. Okay. This looks at the number of traumas. So 4 or more. Okay. 15% of the women said they had 4 or more. They could identify 4 or more categories. Okay. So that's a fairly significant number. And look at the types of things that we say that we have. Some conditions are predominantly more female than male. Well, what's the precipitating factor? Well, sometimes it's their environment, not necessarily their DNA. Okay. So the body's reflexive reaction to trauma, okay, is activation of fight, flight, or freeze. From birth to death, from conception to death. So one of the things I'll tell my patients all the time, I go, your mama didn't take you to fetus school, all right? So you can do all that thinking you're doing right now, but the bottom line is for 9 months, your body just reacted and responded based on what it needed to do to save itself, maintain allostasis. It learned these things whether you were thinking about it or not. So how you think about it today as 40 or 50, it really doesn't matter. These patterns were being developed from conception, okay, not just what you're aware of. Okay, and these go on. And the other thing that people will say is, well, that's my primitive nervous system. Well, do you know how sophisticated an autonomic nervous system is to regulate all those systems all at the same time every microsecond of our lives? How sophisticated that is? So we call it primitive because of the way it is in neurodevelopment, but it's not primitive at all. But people want to think, oh, that's my other nervous system. I have this big brain now. I can control everything. No, you can't. okay, or you wouldn't be sitting in my office right now, okay. So autonomic rapid cycling, okay. So normal autonomic cycling, there's, again, rest and digest down here, okay, fight or flight here, all right. Our body naturally cycles. There are times where our body's excited. There's something, work stress or something that we have to deal with, and then there's times where we should be sleeping or digesting or whatever else, and that's a normal, okay, cycle. But what happens, okay, in life is that something will start a rapid cycle of our sympathetic nervous system. Something, again, where I'm having a significant fight or flight reaction, okay, and that cycle can happen over and over and over and over again, okay, through life. People with sleep disturbances, why can't I just stay asleep for 6 to 8 hours? Because your body's rapid cycling. So when it should just be doing this, it's doing this. Okay, so all of a sudden I'm wide awake at 1 o'clock in the morning. Okay, then I can get back, then I'm wide awake again. Okay, and then, oh, I had to go to the bathroom. Well, guess what happens with sympathetic rapid cycling? Urinary urgency. Okay, so it's not your urinary tract that's waking you up. It's your autonomic nervous system that's rapid cycling. And if this cycle continues to go higher and higher and higher and higher inside the body, what will happen? If my heart rate keeps going up, if my blood pressure keeps going up, if my respiratory rate keeps going, if those things just keep going higher and higher and higher, what will happen? I will die. Okay? On the other hand, if my body continues to cycle through the parasympathetic and go lower and lower and lower and lower and lower and lower and lower, what's going to happen? I'm going to die. Okay? So this cycle is life-sustaining under these circumstances, but it's an incorrect answer based on the present circumstances. But something has triggered my body, and then it will continue to rapid cycle under stress. Okay? So, and this is a handout now we keep in our rooms, all right, and we share this often. People say, oh, no, you don't understand. I got digestive issues, and I got immune issues, and I got blood glucose issues. Yeah, I'm good with that. It's all here. No, it's not a separate piece of paper for those things. They're all here. They're all part of either sympathetic nervous system activity or parasympathetic nervous activity. Well, but I get a dry mouth. But, you know, it's just normal at my age. No, it's not. It's not normal because it shouldn't be doing that. Okay? But if it's doing these things also, guess what will happen concomitantly? I have reduced salvation. Okay? When the zebra is running away from the lion, salvation is not what it's interested. Salvation is what it's interested. All right, saving its life. It's not interested in how much water is being going into my mouth. Okay, so we keep this slide to show patients that all of these seemingly unrelated dots are completely related. Okay, and it can all be corrected. So when we look at disorders of the autonomic nervous system, all very familiar terms. Okay. And one of the things that I talk to people a lot, we're having just amazing time with concussion patients, post-concussion patients, trying to get people to understand that these people are in a rapid cycle. When your brain's been injured, your body's in a rapid cycle. That is not mess around stuff, okay? So therefore, if you can stop the body from rapid cycling, the brain will restore normalcy very quickly. Okay, so we're using this technique with concussion patients, but anybody here, one of my favorite things to say to people who are depressed, people say, oh, by the way, I'm also depressed. I go, great. That makes me so happy. Do you know how many times their doctor has said that to them? Never. If you were experiencing all of these things, depression is normal in the system. Depression of the system. Okay, their system is depressed. And they're experiencing all of these things. If they weren't depressed, I would be more concerned. But don't worry about that. That's a good thing. And they're going to hear terms in our office that no doctor ever says, because the doctor's not looking at the autonomic nervous system influence. It's looking at each disease or disorder as a separate entity. Oh, there's another bad thing going on. Oh, I have more bad news for you. I got great news for you. All of these things. Autonomic nervous system. All interrelated. Okay? So the common causative factor, disorders of the autonomic nervous system. Okay? This particular study I put in here because it looked at fear avoidance beliefs, okay, looking at patients with chronic pain, okay. How do I get my patients to do their exercise? How do I get my patients to work and do the things they need to work? Because fear is one of the things that you recognize as holding them back. Well, I don't have a good fear tool. Well, what is fear? Fear is fight or flight. I do have a good tool that helps me to manage patients in fight or flight. If I can manage their fight or flight, now we can get their physical performance. We can get them now. So the level of physical activity was significantly lower amongst older adults with chronic pain compared to older adults without chronic pain. Okay? Flat out, chronic pain creates a reaction or response in the body that's associated with the fight or flight response. Those two things are linked together. Why can't I get my patient to do more? Why can't I get them to work hard? Why can't? Because fight or flight in their autonomic nervous system is still at play. Can I turn that down? Can I turn that off? Now let's get to work on correcting these biomechanical issues, these things that we know need to be corrected. So that's why I put this particular slide in here, because ultimately this has helped us a lot with patients who come in. I mean, I had one patient, God bless her, she came in like that. I mean, she's literally like walking my office like this. So I take her over to an area and I said, "Are you okay?" She goes, "I'm scared to death." I go, "Why?" She goes, "Oh, oh." And I'm like, she's just deer in the headlights. Well, she'd had a proximal humerus fracture. So guess what her doctor tells her, who's a good friend of mine? That's the worst humerus fracture I've ever seen. So guess what happened every time she'd go back for a revisit? So I said to her, I'm a good friend with your doctor. I said, the next time he tells you that, say, "Doctor, come here." And when he gets real close, slap him. Because he's not picking up on the fact she's already scared out of her wits. And every time she'd go back, "Oh, you got to be careful. This is the worst fracture I've ever seen." She's already being too careful. I don't need her to be too careful. We need to turn down this rapid cycle that's going on inside of her to be able to get her to move her arm, to be able to get her to proceed in her rehab and not just try to say, "Oh, don't worry, we're just going to make it hurt more, but don't be afraid." No. What we do to patients is awful when we don't recognize post-surgical patients in fight or flight all the time. And we just try to medicate them and we just try. No, that's a bad answer. Okay? Those people will develop fear avoidance behaviors, and then you try and push them harder. You try and get them to do more. So we spend more time working on the autonomic rapid cycling, and then we get people introduced into. So if I get a patient 4 days post TKA, okay, we're going right into AAT. We're going right into turning down that rapid cycle. Then the knee just bends. Then the knee just straightens. We don't spend any time pushing, pulling. I tell every patient that comes to our office, you do not take your medication before you come here. All right? We need to deal with this. When we deal with this, you won't need your medication anymore. You'll sleep better. You'll be able to drive sooner. You'll be functional sooner. Okay? It's an alternative that we need to seriously look at because the way we're handling these patients post-surgery is awful. How do you break the cyclical pattern of ANS rapid cycling between fight, flight, and freeze? So here's an adverse reaction, all right? Child being abused. That creates this whole cycling, which creates this rapid cycle, which now becomes a pattern in his or her body that will continue throughout their lifespan. So when something else stressful or bad happens, they'll rapid cycle again, and before you know it, they're going down this pathway. Okay. So now if we take AAT, or safe sensory input, we introduce it into the same nervous system. Now what we get is a normal pattern in the autonomic nervous system. That's the concept. So we can't erase the memories. We can't erase those previous experiences, but we can change the safe sensory input today that allows their body to reset the pattern. Okay. So again, experience leads to sensory neurons, which creates sensory reality. Oops, sorry. Oh, okay. Then interneurons, okay. Learning occurs. Motor neurons going to all parts of our body, not just our musculoskeletal system, okay, or efferent neurons, okay, that produce the behavior in the body. That behavior in the body creates a new experience. If that experience is the same experience that it was a minute ago, then the reaction and response is going to be the same. Okay? Successful progression appears to be dictated by the quality of physical therapist alliance, establishment of body awareness, and the experience of control over pain, involving self-efficacy, decreased fear, improved stress coping, and returning to normalcy. If I could take that word out of this quote, I would put allostasis. Restoring allostasis or returning to allostasis. So again, this comes out of our physical therapy journal. This is what we're supposed to be good at. This is what we're supposed to be doing if we're going to be managing pain well, looking at it from all different perspectives, okay, including self-efficacy, fear, stress coping, body awareness, which we're good at, okay, but that's where allostasis in the system will come in. So autonomic awareness training is a systematic 6-step treatment approach designed around the form and function of the central nervous system, the science of neuroplasticity. Scott firmly believes we should no longer call ourselves doctors of the musculoskeletal system. He believes we should call ourselves the doctors of neuroplasticity, because that's really what we do. We neuroplasticize, whether exercise, mobilization, whatever we're doing, okay? And biopsychosocial medicine. The framework of these life tools produces neurological, physiological allostasis, allostasis, enabling directed conditioning of the human experience. So we're just changing the experience beginning right here, right now. No matter how old they are, no matter what they've experienced in the past, we're just creating a new experience so the body has an opportunity to experience life differently and react and respond differently. Now we'll begin to make changes in multiple systems. Okay, and we could go on and on about stories about that. So AAT, the level 1 course, okay, which I teach. I'm actually going to be teaching a course in January that I'd be glad to talk to you about. John, who I introduced earlier, he also teaches level 1. Level 2 gets more into the psycho or the integrating information component of it, and John teaches that in Rochester. And level 3, Scott teaches, okay, pulling it all together. But basically, it's a 6-step or a 3-step process, 6 tools in total, but it deals with all those aspects that now you become your own team. So I just listed the references, and I want to hold any conversation or questions for just a few more minutes because I want to introduce Matt Carey first, who's going to introduce a case from acute care, and then Amanda will come up, and then we'll open it up for questions and discussions. All right? So I think I have to do this. There you go, Matt.
All right. Good evening, everyone. I'm Matt Carey. I work at St. Joe's in acute care. I had the opportunity to learn AAT from Dave when I was a student of his this past spring. I've had countless opportunities to use this in acute care. We were talking about trauma earlier. Every patient in the hospital has experienced a trauma of some capacity, some much worse than others. This is just sort of a picture of someone I see every day up on the ortho floor at St. Joe's, someone who had a hip fracture. In this case, it was a 78-year-old female. She fell at assisted living, right intertrochanteric fracture sustained. She went to the OR. The next morning, I show up to do an evaluation with her. She was alert and oriented, which is more uncommon for the hip fractures. But 9 out of 10 pain at rest, 10 out of 10 pain with all movement. No matter what, she was just in agony there. No history of falls before this. This was really just, an aberrant event in her life, something very unexpected. She had, a history of osteoporosis, AFib that's medically controlled, breast cancer, and then a history of some DJD, back pain in the low back. And then she had a few different surgeries as well. So I started to do more of an objective assessment with her. She was able to move her arms and legs. Sensation was intact. We didn't try any sort of muscle strength testing just because of the amount of pain she was in. With the help of one of the nurses, we were able to as a team sit up on the edge of the bed. It was extremely painful throughout the whole process. She stated she really wanted to give it a try. She wanted to get back to moving, doing everything that she once was, but she was extremely fearful of falling again. That anxiety was really, very obvious. It was really impacting the session. So at that point, we got her back into bed. The pain was too much. Everything was too much. So that was when I sort of decided, it's time for some AAT with this patient. And I don't want it to seem like a last resort type thing because it sort of sounds like it in that case, but it was something based on the presentation, the trauma, the anxiety, the high pain. It was the right thing to do in that moment. So I taught her reflexercise, the first step of the process. It's a breathing technique, which Dave can talk about in his course. A little too much to explain right now, but I taught her how to do it, why it would be useful, and she had some buy-in to that right off the bat. So we did it together. And again, my rationale, the traumatic mechanism of injury, high pain level, and the anxiety. So I taught her that, and we parted ways for the day. The next day I went back to see her. Pain 7 out of 10. She was really excited about reflexercise and the impact that it had on how she was feeling. And she said especially between her doses of pain medication, it was very helpful for her. So with that in mind, we proceeded to try sensory flow, which is the second step. Normally, when I was doing this with Dave in outpatient, there would be a little more build up to that, but since it's acute care and I have really 2 to 3 days with someone, it was sort of out of necessity that we would proceed forward like that. After the sensory flow session, her pain was at 2 out of 10 at rest, from 7 to 2 out of 10, just in a 25-minute session of working together. And then she was 100% on board at that point. So we got up. Her pain went back up to about a 5 out of 10, but she would, that anxiety was not there anymore. She was much more comfortable with getting up. We used the steady aid. Still, there were 2 of us helping her. She was still, in pain, having a hard time moving, but she was much less anxious. She was able to do it. We got her sitting up in a chair. And it was, a good session for day 2 after a hip fracture and ORIF. So then day 3, she had continued doing the reflexercise, 0 out of 10 at rest when I showed up. And that was unreal, really. So we got up with a walker, walked 10 feet. So again, there were 2 of us there. Got her sitting down. After all that, she was about a 4 out of 10 pain. But she was so thrilled to be walking again 3 days after, fracturing her hip. And during that session, the case manager came in and let her know that she had been offered a bed for short-term rehab, and she left that afternoon. But that was the experience, in just 3 days using AAT, in combination with exercising and just your basic mobility stuff in the acute care setting, a great outcome. Gave her the confidence and really helped prepare her to go to rehab, and I hope she's doing well now. I don't know. But just some take-home points. Again, everyone in the hospital in some capacity has experienced a trauma. They're all trauma patients, some much more severe than others, and with that said, has the potential to benefit from AAT. I know the second point, talking about that sympathetic drive, that cycling, pain relief and relaxation are sort of secondary effects of getting that under control. We've been hearing a lot in different PT circles about the opioid epidemic, and this is sort of a little bit of an alternative to that. With this woman in particular, we were able to cut back on her pain meds because we were getting it under control with reflexercise, with sensory flow. On the ortho floor at St. Joe's, it's like an arsenal, all the narcotics they've got up there. If we can do something to try and cut back on that, that would be really awesome. And then, for another hospital-specific thing, cases of pneumonia, the deep breathing that's a part of reflexercise is just something that can contribute to trying to reduce those pneumonia cases, especially in these really sick patients who are having a hard time getting up. So again, for this case and for many others, AAT really was a great tool on my tool belt to help someone at the hospital get ready for rehab in this instance, but many times to get people home too. Yeah.
So anyone who comes in our office now preoperatively, this is one of the things that they're going to learn to take to the hospital, regardless of what the environment is at the hospital situation they're going into, that they can begin to control their pain without having to use the opioids. They can be more cognitive aware, all those kinds of things. And we see them 3 or 4 days post-surgery, and they're just flying, because all of those limitations are not just internal. It's all the external limitations that we create through these other adjuncts. Amanda, come on up. Thanks, Matt. And again, Matt and Amanda will be here for questions and answers after also. Yes, you will.
Should go on this. How do I do it? Oh, I see. Thank you. All right. Hello.
And then that'll advance your slide here.
Okay.
Mm-hmm.
So, very excited to be here tonight to share with you. This is just a very special case to my heart. I had a patient, she 6 years old, basically hospitalized after having a fall at home, diagnosed with metabolic encephalopathy and a UTI. Really of note in her past medical history, she had a CVA in the past with right hemiparesis. I think maybe 5 to 10 years previous to this. Also history, fibromyalgia, RA, irritable bowel syndrome. Prior level lives at home with her sister in an apartment. Pretty much independent with all of her mobility, uses a bus for transportation, but disabled from work really post her CVA. On evaluation, definitely reduced independence, with all of her functional mobility, particularly when she would ambulate, into contact guard, but then with right foot drop that she had due to weak dorsiflexors and tone in her plantar flexors, periodic tripping that would require max assist to stabilize. She also had this ongoing dizziness that seemed to get worse post her hospitalization, particularly with position changes, even just doing sit-to-stand transfers. In checking her vital signs, blood pressure was stable in it. Also, part of her presentation, she had a right upper extremity flexion contracture. Definitely impulsive with her mobility, would just, you'd go across the room to grab a piece of equipment and she's up on move going somewhere. But also just, I guess, a little bit more of the social component. She was very resistant to any suggestions. My coworker actually originally started with her, and, with the foot drop, she suggested an AFO, and it was no, 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 no. Like every time they suggested it, just no. And often would have angry outbursts and would feel horrible about it, would be, apologize. But she also had very poor eye contact. I mean, this was kind of her posture in the gym. Very guarded, isolating herself to the room, definitely wanted to sleep mostly, just very defensive and untrusting overall of all of us. She also has expressive aphasia and pretty limited with her answers, more so to yes or no questions. She certainly understood what we would say, but just getting that verbal response was challenging. So, we did all the traditional interventions, functional mobility training, strength and endurance training, balance. She received OT, speech therapy. Also, we have a vestibular therapist in-house, so she saw her as well. And we incorporated AAT pretty early on. Most amazing thing, the first day I worked with her, again, like you could just tell the distrust, but she was willing to at least try whatever, we did. That afternoon we did sensory flow, and the next day, I asked her, so how'd you feel afterward? And her face lit up, and she said, happiness. And then she touched her face, and she said, baby. And you could just see the change, like just that it clearly had a powerful experience. Over the course of our therapy, I think the vestibular therapy definitely helped, but even in our sessions still, like we'd do sit-to-stands, and she'd get super dizzy. We'd sit down, we'd reflexercise, and she could go again. She could continue again with the treatment. She really desired to be challenged more. Where we saw resistance, she was getting into quadruped, she was working on dynamic surfaces. We were going all over the facility. She actually had been a part of the program at St. Camillus, and she sought out to walk down there in our session so she could say hi to people she knew. So we were, through her rehab, her walking was certainly getting better, but still occasionally she would trip on her toe. She'd catch her toe. So I was like, this is an AFO. This could help. And she looked at it like she never saw it before. And even though she certainly had been introduced to it prior, and the first time she put it on, she couldn't believe it. How much easier it made her walking. And the word happiness. And also in being challenged, I was able to progress a little bit into some of the level 2 AAT techniques, and it does involve speaking. And she actually wanted to do the speaking, which is something that she's usually or had been very guarded to do. She was sitting in the hallway. She'd constantly be outside of her room, and when you'd walk by, you'd just see a huge smile. She really became a part of our group. We're a pretty close-knit group on the rehab floor, and she'd be up at our watering hole, she'd see the desserts we had that day, and she'd just go over and she'd just say heaven, and chiming in with the conversation, we're talking about hairstyles, and she gave her opinion, in the way that she could, so it was beautiful, and of course she gained back independence with her ambulation, stairs, everything that she needed for to go back into the community. It really was a transformation, and what I saw in her too is she reconnected with a part of herself that who knows how long it had been lost. And when she left, this was very touching. In her exit interview with our case manager, they asked, so how was your stay here? How was your therapy? And she referred to myself and my coworker from occupational therapy as her best friends. And I've never had that happen before with a patient. And I think, as it was already touched on, we see these people who, can say they're a train wreck or there's just so much going on, and I think our heart always goes out to them, and we just kind of disconnect because, you think you can't make a difference, and this is a way to connect with people that you think are unreachable, and I think that's so empowering as a clinician and as just a human, and I think it's a way of also helping to improve people from the inside out. That's that.
Go ahead.
So these are both instances where it was a pretty effective quickly.
Right.
Usually how long after you looked at someone and said, I think they may benefit, how long do you carry on AAT before you decide it's not working?
One of the things and that's a great question, one of the things that I've learned through experience now, and John can probably share some too, one of the things I've experienced is that patients will come back on, for example, the next visit, and they'll say, this may sound strange. And I go, okay, well, my back pain's no different, but ironically, my urinary frequency is better, or my urinary urgency is better, or I'm treating a physician right now. He's been gluten intolerant for he doesn't know how long, and last week he ate pizza and didn't have a reaction. And so we can't control when and how, where they're going to experience change. It can be in their affect, can be in any number of systems, but it gets them to recognize that interrelationship between all these systems, there's something to this. And so I had a patient ask me one time, she goes, well, what if they don't budge? And I said, I think I know what you're asking, and that's exactly what she was asking. What if they just don't get better? And I said, I've never had anyone invest in this and not get better. I have patients who don't budge from square one, and I'm good with that. They can go back to the gym. They can have any other services that we offer or anything else. But the reality is, this goes back to McKenzie, anybody else, that the reflexercise step one is self-generated. You need to go home to do this 15 to 30 times a day. That's your investment in this process. Then as you experience life differently, as you experience an experience, Now your body will start to experience today differently. How it changes autonomically, we can't control that, but it will start to make positive changes, and then that starts to get an investment from the patient. So sometimes it's not always there. The symptom that they are complaining of presently as the musculoskeletal symptom, sometimes that's not the first thing to change, but something will change, and then they'll go from there. We had a woman, 91 years old, who we saw 4 days. We saw her preoperatively. We prepared her with AAT. She came back 4 days after surgery, no subacute, no home care, right into outpatient. We got her off her medication. She was doing AAT. So we do one AAT visit a week. We do one gym visit a week, and we would do it that way. And so she lived in Pennsylvania. And so the beauty was when she was done, because she was up here with her family, because they were up in, deal with her post-surgical care and stuff. So she said, I can't wait to go home and see my friends, because she lived in an independent apartment building. And we said, she goes, yeah, my apartment's on the second floor. I go, yeah, you're probably going to go up and down those stairs. She goes, no, my hair and my nails, I can't wait for them to see it. Goes, my hair and my nails have never been this good in years. All right? And again, I can't say it's exclusively due to AAT, but again, people will see changes because of the autonomic nervous system. We can't harness it. Okay. So again, it changes their perspective. It changes their perspective preoperatively. And so, again, lots of times it's getting people to experience something differently. And then that really escalates the process. So like Amanda and Matt both said, that both patients experience a significant change either in pain or in their affect personality that they can't ignore. All of a sudden, something's happening. I don't know what this is. John.
The most fun I've ever had is Colin Dave 2 years ago.
Yeah.
And then Dave teaching the course.
I needed CEUs. Selfishly, that was the bottom line. Yeah. Yeah.
So he comes over. Says, what's this like? They got it.
Yeah. Yeah.
And so when you get to be able to help someone, help me so great, I know that. And our brains work similarly. We take in information and we be able to determine what's really important to us, and then we got something else with it. But being able to show him some of the things that I learned is one of the great experiences I've ever had, and I'm taking it to another practice. My practice is Western. You cannot swing a dead cat and not have a piece of this.
Mm-hmm.
About 25% of my practice built in modalities, and it's a way to be able to have that market, which we're all going to need, because we're going to have to be able to look someone in the eye and say it's worth this much.
Mm-hmm.
And as you're able to get the skill set like this, you don't have any problem. I don't have any problem looking somebody in the eye and say, look, it's $150.
Mm-hmm.
And it's going to be $85 per day. And I don't take that for anything. My partner does. I don't take the time, and these were business risks that I took on, essentially because I'm like, and I would like to think that I'm a bit confident myself, but it's essentially I don't want to chase all the Medicare crap that you have to chase. Right.
And just to dovetail that, to answer Rob's question also, I couldn't do this. And that's one of the biggest things that why I'm so glad to be able to talk to a new audience about this. I couldn't do this if I hadn't done this. It's my nervous system communicating with my patient. It's Amanda's nervous system communicating, her new nervous system, my new nervous system, recognizing that we all have some degree of this in us. I don't teach this. I don't do this. I share this now. That's why I had to do it. I had to go into the practice. I could have stayed the sports guy for the next 10 years, gone off, been the biomechanist, but experience the physical emotional, cognitive changes that I experience by going through the process is something that and so when I'm sitting in a room with a patient, they don't have a prayer, all right? Because me's just going to gush out. And if that's not if my vulnerability, including the science and all the explanation and all the theory and everything else, don't get me wrong, it's ultimately my experience sharing with them that gets their nervous system that says, this is something that I've never experienced before, at least particularly not in a trauma situation or in a medical situation. So for each and every one of you, when I say that, we teach the courses, it really is for you to experience this, gain an understanding so that you can apply it to patients. But it is you budging off your square that allows other people to budge off of their square. Mm-hmm. And I will say, I walked in the room, I said, this is John Barnesy. I'm out of here. And by 10 o'clock, I was like, I need this. I don't know why, but there's something about this that really resonates with me, and it has transformed. I didn't have chronic pain. I didn't have any, but just personality, characteristics, things that we say, well, it's just who I am. Oh, it's just my trauma drawer spilling out onto you is really what it is. Okay.
Thankfully, Dave did an in-service tank for North.
That was not on this. That was on a different topic.
My coworker would not let me leave without getting screened by Dave. And he saw that I was rapid cycling, and he thought he flipped sideways. Thank you. Your exercise, and I wouldn't be here today. This is the first Central District meeting I've ever been, and I'm happy to be here.
And how many presentations have you done in your lifetime, Amanda? That's right. That's right.
There's something objective in measures. For those of you who know Dave a long time, how big was Dave's Adam's apple? How his Adam's apple would be extremely common.
Yeah, I could cut it once a week when I was shaving. Right. Easily.
Now, that's an objective measurement of change within a posture.
Mm-hmm.
Posture is this non-scientific expression of what your brain is experiencing. Good posture is a vulnerable posture. The vulnerability in and of itself, we've learned vulnerability to be dangerous. Mm-hmm. Vulnerability is the only true path to safety. And when I say that, it sounds like it's a bunch of crazy crap. But your nervous system is constantly monitoring every joint, every muscle center, and it's getting information coming in, going in all the time, 365, and it's responding on output behavior. Doesn't recall. You can measure someone's output behavior just looking at it. Mm-hmm. And what this APTA allows you to do is be able to go and help them manipulate it in a way that they can find inner peace, which is a wonderful thing, but they can be comfortable in their own skin, maybe for the first time in their life.
Mm-hmm. Other questions, comments? We really appreciate your attention. I know it's a busy time of the year, getting ready for the holidays and things like that. And like I said, I will be offering a course in January 21st and 22nd. I'll have Dave email the link around, and if you'd like to go to our Facebook page is G&B PT, Golden and Boylan, G&B PT Cortland. Okay, it'll also be on there. But again, the reality is I really want to be able to either come into your practice or come into your educational setting and just be able to share a little bit more about this, because, again, it's a tool that we recognize we need, and people say, well, but where's the evidence for this tool? The evidence is we're not good at what we're doing. We're not accomplishing the task, and the expectations are getting higher and higher. And my final thing that I would say to you, and this is from the bottom of my heart, when I see a physician today, all I ask them is one thing. Please send me your worst patient. That's all I want, your very worst patient. The one patient that you have not been able to help, change, whatever, those are the only patients that I want you to send me. Do you know what that does to your referral basis? When those physicians say, what? Those are the ones you guys keep kicking back. Those are the ones you keep saying, guys, that's what we could do for them. And the physicians, I say, those are the patients. I go to, whether it's a GI doctor, whether it's a chiropractor, whether it's an orthopedist, whether it's a primary care. I just say that send me your absolute most troubling patient. That's who we want in our office. That's the difference in my practice today compared to 3 years ago. Absolutely. I love those people now because we can do so much for them when you have the tools. Thank you.
So to get your CEUs, I do need a completed course eval. If you're here for CEUs or paid for CEUs, please make sure you fill this out and send it back to me.